Well, good evening, everybody. I'm delighted to be speaking to all of you at this special BTOG webinar entitled Lung Cancer in the Time of COVID. My name is Sanjay Popat. I'm Professor of Thoracic Oncology at the Royal Marsden Hospital and Institute of Cancer Research, and we live in exceptional times. COVID has changed the way we treat, diagnose, stage, do everything with our lung cancer patients. And in these exceptional times, we've assembled for you exceptional people to discuss exactly where we are with COVID in thoracic malignancies and how we're going to take matters forward for the rest of the year and perhaps the beginning of 2021. Being BTOG, we have assembled the whole MDT for you. We have expertise from respiratory medicine, from thoracic surgery, from radiotherapy, from medical oncology, from nursing, from pharmacy, and also experts in research. We're going to have a question and answer session amongst the panel here, and I'd encourage delegates to ask your own questions too to these assembled experts using the question facility on the app that you're using. So without further ado, can I ask our specialists to introduce themselves? First of all, Samreen.
Hi, good evening, everybody. I'm Samreen Ahmed. I'm Professor in Medical Oncology at University Hospitals of Leicester. I'm BTOG committee member and run quite a lot of clinical trials, and that's been important in the COVID era.
Thank you. David.
I am David Baldwin. I'm a respiratory physician from Nottingham and interested in CT screening and diagnostic pathways, and chair the clinical expert group for lung cancer, which is recently departed slightly from NHS England, but still well and truly in existence.
Thank you. John.
Hi, good evening, everybody. My name is John Edwards. I'm a consultant thoracic surgeon in Sheffield. I wear a number of hats, and the one that has probably got most relevance for this evening's webinar is that I chair the thoracic steering committee for the COVID surge cancer study, which is recruiting with tremendous success worldwide. So hopefully we may be able to get onto some of those.
Thanks, John. Matthew.
Hi, Matthew Hatton, also from Sheffield. I'm a clinical oncologist. I think my other relevant disclosure is that I chair the NCRI Lung Studies Group.
Thank you, Matthew. Josie?
Hi, I'm Josie Roberts, Macmillan Lung Cancer Nurse Specialist at Rotherham District General Hospital. Cancer Centre is Sheffield as well, and I'm a committee member of Lung Cancer Nursing UK.
Thanks, Josie. And Rhiannon?
Hi, I'm Rhiannon Walters-Davies. I'm the Principal Pharmacist at Falindra Cancer Centre within Cardiff. I'm the lead lung cancer pharmacist there, as well as being a non-medical prescriber within lung cancer. And I'm also the policy and publication lead for the British Oncology Pharmacists Association, so BOPA.
Well, thanks very much for all of you for giving up your time today. And let's get stuck right in. So the first question to David. Respiratory medicine has really taken a huge toll with, in some places, the coronavirus surge, and in other places, the gradual gradient. Tell me, what changes have respiratory physicians had to make in diagnosing and staging lung cancer?
Yeah, well, I think it's a difficult question because I think the response in different parts of the country has been very different according to the sheer volume of COVID cases that different centres have had. And speaking for the very high volumes centres and the stories that I've heard there, people have really had to, at least for a very short period of time, almost completely shelve the diagnostic and staging process. That's one extreme, and then rapidly pick that back up again. Whereas in areas where the social distancing obviously worked rather more quickly and the volume was reduced to some extent, we've had a different approach. What we've seen is that people have not come up to the service. There've been a vastly reduced number of attendances. It's down to 20% of what it should be for the peak months in the COVID pandemic. And as a result of that, we found ourselves on the one hand, dealing with some of the COVID work, and on the other hand, having more compact teams looking after all the lung cancer patients, and trying where possible to keep the diagnostic and staging process going as far as possible. And that's reflected in some of the national documents that the CEG produced with the help of many of the people on the panel here, but a wider group of people that certainly this has helped, I think, with some people to drive the continuation of services, because what we can't do is to let our patients down at this time. And so therefore there have been a number of sort of little tweaks to the national optimal pathway and the diagnostic process that we've recommended, particularly and notably at the early stages of the pandemic. We felt that over-reliance on the diagnostic staging through EBUS was perhaps something we could maybe just reduce slightly by using PET, and then really going on what the PET said rather than necessarily being purist about it and sampling it, say, in large nodes with no FDG uptake. Now that does come at a risk of missing metastatic disease, but we sort of accepted that. And then in the next iteration of our document, of course, we've now relaxed that and said now resume the normal diagnostic process. Whether we will need to reduce our accuracy of diagnosis and staging in the future will depend really very much on the local prevalence. I sincerely hope we don't have to.
Thanks, David. I'm going to bring John into the conversation. John, thoracic surgery has had to hugely change. There are now surgical hubs, I understand. Tell me about the surgical changes you've had to make and what's going to last.
So I guess the biggest issue that we had as the pandemic grew was not knowing what were the risks of surgery. And it was clear from early reports that came out of China that the risk of operative mortality in a COVID positive patient is extremely high. And the first report was about 30 or so cases with a mortality rate of about 35 or so %. That clearly set alarm bells ringing when we realized that the main reason of mortality was respiratory. So effectively the where we went from there was a need to understand more, but at the same time to consider very carefully on whom we operated. So in the early stages of the pandemic, we found ourselves not doing very much surgery at all, only the most urgent cases, but with a great desire to learn more about the risks. And only when we have information about the risks did we feel that it was safe to try and re-expand services once again. So this is where the NIHR Global Health Global Surgery Unit in Birmingham came to the rescue by setting up the global project COVID Surge, which has now got about 34,000 cases of both COVID positive surgery and also cancer within it. And that has provided a lot of information which is beginning to come out. And some of this information is confirming what we know about the risks, but also now beginning to show that actually the prevalence of, or the incidence of COVID in the surgical population is actually very small. So I think that's the first thing that understanding, and we may go into that in greater detail, but that's the first aspect, of trying to understand the risks of surgery. But at the same time, the actual delivery of service has changed tremendously in terms of the fact that initially many of the cardiothoracic anaesthetists and theatre team were redeployed to cover the expanded rota within critical care, and that had an impact on our service delivery. And that has now, in the UK at least, has gradually recovered, although elsewhere in the world, I'm well aware that the delivery of cancer surgery is still at a very low rate. Then beyond that, there's been the need to consider personal protective equipment in the operating theatre environment for staff, bearing in mind that the buzzword that we didn't know at the beginning of the year called an aerosol generating procedure, and that there's a lot of maneuvers within thoracic surgery anaesthesia as well as surgery that are aerosol generating, and that has had a big impact on the way in which we work, the equipment that we wear, and that has knocked on to our, frankly, staff stamina to undertake the same throughput that we had before, but also the staff numbers that are required to conduct surgery safely. So that's had a big impact, and again, we are just beginning to see ourselves coming through the other side, but quite where this is going to lead us in the near future is still yet unknown.
Thanks, John. A question to Samreen in terms of systemic therapies. NICE put out some interim guidance on changes. Maybe you could run through some of the highlights and just tell me personally from your viewpoint and reflecting what colleagues think, what's been welcome, what's not been so welcome, and what do you think might stay?
So the general guidelines have suggested that treatment that we deliver should be less immunosuppressive, should be less resource intensive. It should have less hospital visits, so we're not exposing our patients to COVID-19 infection, treatment at home as much as possible. GCSF has also been supported for any regimes that cause neutropenic sepsis beyond 10%. And these are all different thresholds that we were previously used to. So specifically, the interim guidance has allowed us to give pembrolizumab first line for any PD-L1 positive patient. So previously we were only able to do that for over 50% PD-L1 expressors. So to try and avoid chemotherapy in the first instance, that's come in. The schedules have changed. So what we were used to previously 3-weekly pembrolizumab has now gone to 6-weekly. And that's really been adopted quite quickly throughout the cancer centres that I'm aware of, and certainly for us, that's been done very quickly. Adjuvant treatment following concurrent chemoradiotherapy with durvalumab, another immunotherapy, which was previously given 2-weekly, has gone to 4-weekly, and that's been welcome with regards to capacity and patient visits to hospitals. So the other, I guess, the regime that in the UK we're not that used to is carboplatin paclitaxel. That's been suggested to be adopted rather than day 8 regimes like carboplatin gemcitabine regime. So again, you're getting less input into the hospital, less footfall, less exposure for the patients. I think that's not a particularly popular schedule here, but appears to be the standard in the world. It's a very good regime, but does have hair loss, whereas the other regimes do not. What I have found personally the most important interim COVID changes is first-line osimertinib for EGFR mutation patients, and I found that very useful indeed. What I would have liked to see actually is introduction of second-line osimertinib without a biopsy, because currently, that's restricted, but also we've got difficulties in biopsying small lesions, even outside of COVID. Specifically now with COVID, we're trying to reduce exposure to patients as well as to our staff members. And so we're trying to reduce EBUS biopsies as much as possible. And so, the balance there to try and get a T790M mutation, which is required to give osimertinib second line, is still there. So what I would like to see is that change, because actually bringing osimertinib first line hasn't really changed the chemotherapy for EGFR mutation patients for subsequent therapies. So in that way, it's been welcome that it's now first line, but I would like to see it coming in second line also. Personally, I found the carbotaxol hasn't really been an issue so much. I haven't really adopted that as greatly because we, as medical oncologists, we tend to see mainly adenocarcinomas, and we give carboplatin pemetrexed, which is again a Q21 regime anyway. So a lot of things have been welcome, and I hope they will stay. A few things have not. GCSF introduction is very good for small cell lung cancer, and most of us were doing that anyway prior to COVID. So.
Thanks, Samreen. I'm going to bring Rhiannon in because many of these changes will have affected pharmacy as well. So what changes have pharmacy had to make because of the coronavirus pandemic? And importantly, what changes will stay because they work and they're actually better practice?
Yes, thanks, Samreen, for running through those interim guidance for us. So yes, I agree from pharmacy perspective, we did have to rapidly support the development of treatment algorithms, protocols, the e-prescribing that went along with it, the off-licensed and unlicensed indication, paperwork that needed to be completed. We developed the prioritisation plans for SACT, as with the NICE guidelines. We were involved in identifying the suitable patients for appropriate switches in formulations, moving those devolumab patients from the 2-weekly to the 4-weekly, doing the counselling along with those, looking at dose reductions, flagging at times where we thought the pegfilgrastim would be useful in, in those immunosuppressant groups. We were involved in ensuring there was sufficient medicines supply, really, not just for SACT, but all of the COVID stuff. Particularly with my role as procurement lead within the trust, there was a lot of 2 a.m. checking the oxygen tank cylinders and that type of thing. We also extended our NMP support within Velindre, so to allow medics to go back to frontline work, so either by additional sessions of NMPs, pharmacists, or to extend NMP scopes of practice to widen. So there was clinical changes, but there was also as you imagine, a lot of operational changes that we needed to do. And as Samreen talked around, was, trying to facilitate home care and use of alternative delivery methods for SAC delivery. So, we use home care providers, so as well as reducing patient exposure, it also helped us give capacity in the nursing and pharmacy teams as well. We also, some trusts looked at using courier services to be able to deliver medicines. As at Velindre, we did a drive-through service, basically. I think we did miss a trick we should have co-located with the McDonald's and the Starbucks that's round the corner, if I'm honest. I think we missed a trick there. There was lots of other things as well. We used COVID light sites as well. So we removed all of our face-to-face and day case administration from DGHs back into the hospital site. We also looked at the medicines that we needed to use when we were looking at private hospitals and regional cancer hubs and mobile units. So there's a huge amount of work, really. Obviously, our workforce had to adapt as well, move to 7-day working, virtual meetings, looking at the how social distancing impacted it with regards to our dispensary, our aseptics, waiting room capacity, that type of thing. So altogether, there's a big change for pharmacy, if I'm honest. We quickly had to adapt, and that isn't something we're well known to do, if I'm honest. So all of the changes that we've seen, I wouldn't say that any of these sizes fits all, and each hospital will have to look at their departments and decide which models they're going to take forward. Although from a pharmacy perspective, I think we're of the opinion we know there's no going back. I think the changes that pharmacy had to do at the time demonstrated that pharmacy can make decisions quickly, and pharmacists are able to be flexible with solutions. I never thought I'd be using Google Translate to work out where the Swedish propofol was actually real propofol that we could use, but strange times call for different things, don't they? So what we should really take as a pharmacy is that, making sure that we can take forward our autonomy to make decisions quickly and implement at pace. So rather than any specific guidelines, I think what we need to take forward is that we can do this quickly, which isn't always thought of as pharmacy.
Brilliant, thanks. And I'll just bring in Josie. Josie, CNSs have had huge changes in the way you work with the pandemic. What's worked for you, and what do you think you'll be taking forward?
I think certainly initially many teams were redeployed. Certainly we nationally and within the Lung Cancer Nursing UK, people with A&E experience, people with ICU experience were redeployed there, or certainly helped out to support colleagues. Locally, we were helping with the chemotherapy regimes and helping intensive care colleagues supporting COVID patients through telephone and video consultations. So big changes, lots of it around communication as well, which I think has been absolutely critical in managing patients and their families and carers' expectations. I think one key thing I've learned from this is I work back, having a specialist palliative care background, work with the palliative care team And it really did emphasise the importance of having excellent palliative care and best supportive care for many, many of our patients. Especially, we're seeing increase in patients admitted with advanced and metastatic disease. I think the issues with not having visiting in hospitals put a lot of emphasis, a lot of strain and pressure on families going through any treatments. I think the other area is the telephone consultations have been absolutely essential. And I think we really need to develop these much more into video consultations, having much more electronic forms of being able to communicate with all our patients and the families. Bear in mind that no visitors have been allowed, and clinics, we do allow one relative at diagnostic clinics, but that's been extremely difficult for patients to take on board, I think.
Thanks, Josie. And Matthew, from the radiation world, you guys from your college have issued guidance. What's worked for you, and what do you think is here to stay in radiation changes?
I think first thing to say is that the stay-at-home message was extremely successful, and numbers of patients coming through for radiotherapy did drop. I think each department has probably reacted slightly differently. In Sheffield, we sort of closed our oligometastatic SABRE program. We stopped inpatient radiotherapy treatment, and most importantly, all trial activity ceased. And what we're trying to do, I think, going forward is use radiotherapy in a way that minimizes patients' risks to picking up coronavirus, and also, I think, keeps the pressure off the radiotherapy departments. Because one thing COVID will have done, I think, is reduced our capacity. I think estimates for our capacity in Sheffield is probably that we will be able to run at 80% in the sort of new normal, compared to 100%. So going forward, it's been looking at regimes that essentially reduce the numbers of treatments given, so reduces the numbers of fractionations. And the Royal College have sort of led in this area. They've produced, I think, guidance across the various tumour sites. Corinne Faber-Frinn is the sort of first author of the document for lung cancer. I think the important thing to say about this is that we've been able to review the evidence. And the evidence for reducing fractionations is often quite modest. We're looking at phase 1 and phase 2 trials. So I think if we are going to adopt these shorter fractionations, we need to do it carefully. Each department will need to set it up and pay, I think, great attention to their techniques and try and employ as many modern radiotherapy techniques as they can. And also, I think it's going to be very important to collect data, to audit outcomes, toxicities from these new fractionations. So I think a number are here to stay, certainly in the medium term, because as I say, I think the ongoing pressure on service will be there through this year, and I suspect well into next year.
Thanks, Matthew. Question for David. You and I guess John are leading the push for patients in the diagnostic and staging part of the patient journey. So the NHS may or may not have diagnostic hubs. I mean, that's the rumour on the rumour mill. Will it work? Can it work? What are your thoughts, David?
So I think this is a generic thought, really. It's about the importance of keeping people that are COVID positive away from the cancer services whilst they recover, because we know that people don't do well if they have COVID. That is a bottom line. What we're not clear about, though, is whether they do any worse than they would do normally if they have COVID, because we have this, and it's interesting to hear what Samreen was saying about the nice interim guidance. That a lot of that was based on just 2 papers from China of very small numbers of patients, and since then there have been 2 papers published which have got 10 times or more the number of patients in them, showing that actually there doesn't seem to be any extra risk from receiving systemic treatment. It's just the fact that you have comorbidities and increasing age, all the usual risk predictive factors that we know are present in COVID in general seem to apply to lung cancer patients and other cancer patients as well. And I think the Lee paper, which is the Birmingham study I think that John was referring to, had 100 or 90 lung cancer patients within it. So, better numbers than the 28 that were in one of the China papers. And the answer to the question about diagnostic hubs, the crucial thing is how well we can keep them green, if you like. And that is one of the reasons why some of the latest guidance from the CEG about how to manage referrals for cancer recommends testing them before they're referred, even when they're the sort of patients that are quite likely to have lung cancer rather than COVID. And it's really designed to try and reduce the risk of cross-infection. And I think a lot of the measures that we need to put in place now need to be focusing on cross-infection prevention rather than necessarily worrying too much about the immunosuppressive aspects. And another little signal for that is the fact that dexamethasone in more severe patients improves the outcome, the mortality outcomes from COVID. And that must be operating on the inflammatory components of COVID. It's not preventing virus attachment. Remdesivir is a drug which does that, and that's generally more effective in the sort of more early stage of the disease, as you'd expect. So I think we need to focus our future management, which may include the RDCs, but certainly on green areas where we absolutely reduce the chance of cross-infection for as much as possible. And that way we should be able to proceed in a safe environment for patients and ourselves and actually get the best outcomes.
Thanks, David. John, do you want to comment on that?
So I think the interesting data coming from the COVID surge study are still in evolution. What I'm just about to say is sub-judice, so it's not in the public domain yet. But if we look at the just over 800 patients who have had cancer surgery that have got 30-day outcomes and from that study, and what we know is that the background surgical mortality from the Society for Cardiothoracic Surgery's audits and the Lung Cancer Consultant Outcomes Project is that the regular mortality for lung cancer surgery is just under 2%. So when we look at the 800 or so UK patients, selecting those ones that are in the COVID surge study, we see that the overall mortality is 2.3%. And if we then split that into those that are COVID positive and COVID negative, the 34 COVID positive cases had a 30-day mortality 35%, whereas the COVID negative patients were just 0.95. That 0.95 is quite interesting because that suggests that the patients that don't get COVID are lower risk than average. And therefore, the understanding of the risk of these patients in terms of the regular surgical risk is going to be very important. So if you think about excess mortality as a result of the COVID pandemic, it goes from just under 2 to 2.3%. So there's maybe 3 in 1,000 patients that are succumbing to operative mortality as a result of COVID. So I think we need to put it into context. And thankfully, the fact that we've now got about 1,800 patients with lung cancer in COVID surge, all with collection of risk stratification data, will allow us to look very carefully at the risk of the patients that develop COVID and die versus the risk of the patients that survive. And so that's going to be very interesting to see. So it looks as if it may well be that some of the patients that succumb to COVID post-op are those that are likely to be higher risk in any case.
Thanks, John. And, you know, one of the things that we need to start thinking about is risk. So should all patients that are surgical candidates still get surgery, or should actually they be seeing a radiation oncologist for SABR? So I'll have your brief thoughts on that and then ask Matt afterwards.
I think it comes down to our understanding of risk. And now we have the knowledge that the risks in a patient who has been shielded and is tested negative with our current protocols beforehand is very low of developing COVID. I think we can go more or less back to business as normal. I don't yet have the data from all UK units, but we haven't seen COVID in a lung cancer surgery patient for over 3 months. And I think if we continue to exercise a high standard of screening and and COVID minimisation, I think we can continue business as normal in terms of case selection. There are still issues in terms of service delivery, but in terms of case selection, I think we can continue as normal.
I'll bring Matthew in for your comments about SABR and patient selection. Matthew.
I think I'd largely agree with John. I think patient selection should be really business as usual. I think there are, I suppose, over the coming months, likely to be areas where COVID perhaps re-emerges, and you may have to add that into your sort of risk factor calculations. But essentially, I think any patient who has a higher than average risk for surgery probably ought to be seeing a radiation oncologist to discuss SABR as an alternative treatment. And I'm not sure that situation is any different now to what it was sort of at the end of last year.
So one question that's come in is about pre-procedure testing of COVID. Now, the surgeons have done this very nicely. Patients are shielding. They have to test beforehand, be negative before they can have their procedure. Samreen, should patients undergoing systemic chemo, which we know is myelosuppressive, may not mix well with COVID, also be undergoing regular COVID testing? Don't you feel hard done by for your patients because they're not?
Yeah, completely. I mean, there is a national guidance document still waiting to be ratified coming through, and having my ACP hat on, I have had sight of this, and there's views are divided in the country with regard to their capacity of testing, because we're not talking about a small volume here, as you can imagine. For big centres, where throughput is 90 patients having sacked IV only per day. So if you bring in the orals, there's probably double that easily. My personal feeling is that we should be testing everybody. Just because we don't have capacity doesn't mean the principle should fail. And certainly in the private sector at the moment, if I see a patient there, I'm being tested every week. Patients are all being pre-screened before they have treatment for the local private hospitals here. I'm quite a strong advocate of supporting that for the NHS patients, and at least we need to start with the new patients, if nothing else. If we can then introduce it slowly into our existing patient caseload, that would be ideal. But again, it does mean that the actual dynamics of that and the pathways just need to be streamlined a little bit, because it means that the patients have to come in 48 or 72 hours earlier from their actual treatment, which means another extra footfall into the hospital and contact with other people, puts them at slightly a higher risk. And then, of course, who's going to do that checking of the results before they're given treatment? Because most of us clinicians are doing virtual follow-up anyway. So, even though I'm a strong advocate of testing for our cancer patients, I feel it just needs a little bit of work with regards to capacity testing, what the pathway should be, how are we going to actually implement the test results and act upon them before we give them their systemic treatment.
Thank you. I'll bring Josie in because, I guess the CNSs have been supporting our patients right the way through this difficult period. It must be, really difficult for patients who are undergoing a procedure, having to shield, having to COVID test. How have you managed to support patients through this journey, Josie?
Absolutely. I think there's been such a big fear factor throughout for all patients, and as I've said, for their relatives and their carers. For patients coming through investigations, we've been doing some of the actual swabs, the testing. I think patients appreciate this. I think they want, proof that they have been tested. Certainly for any biopsies, CT biopsies, any further treatment, we've had to have the testing in place and contacting them as well with results where necessary. And I think patients have all accepted this new sort of reality. They're scared to come into hospital so they can have remote drive-through testing. I think we just need to minimise the amount of time they do have to visit the hospital face-to-face. But equally, they need to appreciate the risks involved as well. So there's been a big impact, I think, on all lung CNSs in supporting the people throughout this.
And Josie, you know, obviously for patients that are admitted, visitors aren't allowed. That doesn't seem like it's going away anytime soon, or does it? And do you think that's a good thing or a bad thing?
I think presently it's still a good thing. We've certainly minimised the visiting. You are allowed one same relative throughout for end of life care. And I think we have to continue that, because we can't say a lung cancer patient or a cancer patient can have a relative and other patients can't. So I do think that's important, but I do think the emphasis on video consultations, the use of IT technology has been imperative in supporting this, and constantly, you know, informing your patients of what's happening. The communication aspect is just essential throughout. And I think most of that has fallen obviously on the CNS.
Thanks, Josie. And, you know, part of our new way of working is COVID testing patients before procedures, as we've discussed. David, question to you that's come in. The BTS have recommended that patients that are having a bronchoscopy or EBUS who have a COVID positive swab have the procedure delayed by 28 days. Is that a good thing or a bad thing? You know, because on the one hand, we're trying to get people through the system as fast as possible. And on the other hand, we are slowing things down even when they're asymptomatic. We know, for example, that 40% of people are asymptomatic or perhaps will never get any symptoms. Is that an own goal?
I don't think so. I mean, I think that there is a qualification in that document about people that are very urgent patients. So this is, as we've said, it's a relatively few people. As the prevalence increases, the prevalence of people that are at risk of dying increases as well. So as the prevalence falls, fewer people have positive swabs, and therefore fewer people will be affected by this. But at the time of writing that document, we took advice from members of NERVTAG, and we felt because this was a procedure that was something that could be delayed by that amount of time, then the 28 days was the best approach, particularly as these people would have been in contact with others as well. So the standard shielding time, of course, is 14 days, but not everyone. In fact, that is a sort of an adjustment based on what's pragmatic as opposed to what is to ensure the patient is completely clear of being infective. The infectivity really goes completely at around about day 21. And even beyond that, there's some evidence that people can still be infective. So that was why we went for 28 days. You could say that could be modified now to 14 because of all the other evidence that, or all the other guidance there, but we've not elected to do that as the prevalence is now dropping, and this is not going to affect very many people.
Thanks, David. With for the panel, with COVID testing occurring in so many different ways, some people are having it done in the community, some people are having it done in hospital. You know, how are these COVID negative tests being signed off? So, for example, if you're coming in for a procedure with John, and John, I'm going to ask you this question. If you're coming in for a procedure with John, whose responsibility is it to ensure that the patient is COVID negative? And can the patient just not simply schedule a COVID test, you know, at their convenient time point using the government mobile unit, for example, rather than your specific COVID test, John?
So I'm not an expert on COVID testing and what can be available where, but I understand that there are pillars, and I suspect that David might be able to tell me more about pillar 2 than I know. But certainly from a preoperative assessment clinic point of view, we provide the testing because I guess we want a quality assured test that has been through our system. And we're also doing testing in our institution where by post. So we are, as part of the preoperative process, the patients are instructed to shield for 14 days, and we know that that is difficult, particularly if they're elderly and dependent. And 3 days pre-op, they perform their own test, which I accept may have quality issues. which is sent back by post and is rapidly analysed, so that we have a preoperative hospital performed test done immediately before surgery. And obviously we would not be operating on anyone who is positive. Have we yet had a positive test? I don't think so in our institution. And as I said, we haven't had a positive patient for 3 months. But I know that in other parts of the country, and dare I say other parts of the world, there are different experiences.
Thanks, John. One of the most controversial pieces of the various guidelines that have been published in the UK was to consider omitting adjuvant chemotherapy. Now, I can understand why that was said, because presumably of the increased risk versus the presumed minimum survival advantage, but others have argued that this is curative treatment we're talking about, not palliative treatment. Samreen, can I bring you into this and ask your thoughts on that area of controversy?
So I treat breast cancer as well as lung cancer. So there's a lot of adjuvant treatment given in breast cancer. For lung cancer, I do think the adjuvant chemotherapy is fairly high risk, even without the pandemic without the pandemic going on in the background. I just think you do have to stratify your patients very carefully. So as John alluded to in terms of surgical workup, and the risks for patients who have comorbidities is still there, if not heightened. So it is those people that you would normally not give chemotherapy to that I would still omit. Those people who we feel would be able to tolerate treatment well and not have infection. I would say the recurrence risk for higher stage lung cancers is high, and so I would say that adjuvant chemotherapy again has to be assessed with regards to its risk. And the shielding message for our patients has been really very well observed, and we've all found that we've had less footfall into the oncology units, and actually the normal sort of neutropenic sepsis rates are actually much lower, and that's because patients are observing shielding very strictly. So I think under that environment, clinicians are able to deliver chemotherapy, whether it's adjuvant or palliative, in a safe environment.
Thanks. And related to that, I'll bring Rhiannon into the conversation. So when patients are having their systemic therapy with this strange new world of digital conversations and restricted visitors, how can we ensure patient safety and compliance in taking their treatments when it's not intravenous? How do we know they're actually going to safely take the complex regime that Samreen has prescribed, for example, or you've prescribed, for example, Rhiannon?
Yeah, there's obviously a concern from our perspective that obviously the traditional touch point where we do get to counsel patients, where we hand over the medicines, particularly if we're using, home care delivery, couriers, drive-through, there's a loss of that. So we just need to make sure there's alternative mechanisms where patients can access that. We've got an absolutely great education service at Valinja that's run by our technicians, actually, so not pharmacists. And they've just tried to migrate their current service into a online counselling service. So, there's a digital walking now clinic where patients can ring up and ask. We also give them information when, along with all the SACT information, they also get a please call this number. You can book in for a counselling session online. And it's probably the right time really to have a discussion really with pharma about how we move from the traditional patient information leaflets that are, paper-based to actually making a co-produced virtual content that we could share with patients online and then adapt per trust as well. So, there's lots of things that we can take on using virtual platforms, but we also need to bear in mind there are some patients where virtual platforms aren't the answer to everything. You know, we do have some patients, you know, I had a patient who was hard of hearing, came into clinic because we thought that was the easiest way, but actually she can only lip breathe. So me wearing a mask wasn't really helping the situation. So there's cohorts of patients that we need to make sure that we've got a wraparound for as well, that isn't just reliant on, you know, moving everything to virtual platforms really. So there's work to do there, I think.
Thanks very much. I'm just going to ask Matt a question. One of the things that one of the questions that's come in, a theme of the questions that's coming in, is the changes in our treatments that we're doing, be they radiation changes or systemic therapy changes. Have we noticed increasing toxicities with this? Because, you know, you pointed out that the hyperfractionated regimes really don't have that strong data to support them. So, you know, are you noticing more toxicities with your hyperfractionated regimes than you would have been doing otherwise? And what mechanisms have we got placed in the UK to monitor the safety and perhaps effectiveness of these novel regimes? Matthew?
I mean, I think I can only, I suppose, speak from personal anecdotal experience. Certainly, I've been using some of these sort of hyperfractionated regimes. For example, the concurrent chemoradiotherapy regime, using a sort of 4-week radiotherapy fractionation as opposed to normal 6-week. And my sort of anecdotal experience is that has produced more in the way of side effects. It has proved a little more toxic. So I think there is a risk there. How we capture and monitor that risk, I think, is difficult. I think the radiotherapy, we do have set up through University of Manchester a sort of radiotherapy service evaluation, so an online assessment where we're trying to capture all patients treated with these newer regimes and capture some sort of fairly basic, I suppose, demographic data and toxicity data. But it's going to be difficult, I think, to really be able to capture toxicity data. You need to be running things as they do in clinical trials, and that does take resource. So if we're going to do this, it's very much now down to the individuals, the individual clinicians who are looking after the patients, to be able to capture and record data, I suppose at first locally, but then hopefully feeding into these larger databases.
Thank you. And we'll bring Samreen into the conversation. Samreen, with checkpoint inhibitors, we're now using increased frequency with higher doses. So, for example, 6-weekly pembrolizumab, 1-monthly durvalumab, 1-monthly atezolizumab, for example. Now, much of these changes have been done on PK modeling, not necessarily in clinical trials. There are some anecdotes which are starting to filter up to my headquarters about perhaps increased toxicities. Is this just anecdotes, or is this a general feeling that you're getting that increased doses have increased toxicity with checkpoint inhibitors, or is this just, you know, people not understanding that dose does not increase related to checkpoint toxicities with checkpoint inhibitors? Samreen.
You read my mind. I was just thinking about that myself, and actually when the pandemic hit, I was actually worried, is it going to be the checkpoint inhibitor patients who are going to be more at risk of COVID complications rather than our immunosuppressed chemotherapy patients? Because, I mean, my understanding of it is this inflammatory response that causes all the complications. So, you know, I was in two minds. We are trying to divert all these chemotherapy patients to checkpoint inhibitor therapy, and are they going to be just as much at risk? And then going to your second point about giving bigger amount of drug less frequently, I don't know. We're auditing it, certainly. I mean, we, as we generally do in Leicester, we take on anything that reduces our capacity, increases our capacity, reduces footfall. We take that on quite early, and we actually switched to pembrolizumab 6-weekly quite early on, way before the pandemic hit. And so we're in the process of auditing it. I can't, you know, anecdotally, I'm not seeing that much more toxicity, but, you know, I'm very happy to be corrected if others around the country are. I am, I guess these patients, I don't start them off immediately on 6-weekly, I have to say. I give them 3-weekly or 2-weekly, and then migrate them over to a longer regime. So it may be just the cumulative toxicity that they were going to get anyway, and we think it's because of the larger dosing less frequently, but they may get it anyway. So I think it's an area of research and audit that we probably need to do all around the country in all our centres as we change practice.
Thank you. A question that's come in from the audience. So David, I think it's a good one for you to answer, David, is about the status of CT screening. You know, we were leading the world, I would like to say, in implementation of screening, very high uptake in the pilots, and that's down to a lot of the great work from many people in the UK. And it got shut down with COVID. David, is CT screening going to come back to the UK?
Yes, absolutely. I mean, all the cancer screening programs were shut down. So, you know, across pretty much the world. And the great thing is that whilst we've been shut down, there have been a number of other countries that have now suggested that they should go ahead with screening. Significantly, Germany have given the green light to going ahead with targeted screening. So it'll just provide a little bit more impetus to carry on. The issue at the moment, of course, is the problem with backlog, which a lot of the targeted lung health check centres are citing as a reason not to start CT screening. But in a sense, the fact that there was an intention to start in any case, or they'd already started, should probably be classified as some of the backlog, because it is intentional work that was to be done. So we're trying to sort of make that argument. There are many of the targeted lung health check programs are intending to start. Some of them have already made plans to begin this year in a limited way. And we have significantly a number of the research studies that have restarted. So YLST started about 3 weeks ago, and they're now going to do their second site just next week, I think. The Manchester rollout is also restarting, and as far as I'm aware, the Liverpool pilot will also restart as well. So it is restarting. Inevitably, it's been delayed, and during that time, we're losing a bit of ground. But I think also the process of slow implementation to what is the ideal, and that is a national program that has equal standing with the other cancer screening programs, is still on the way. So it's just a question of keeping going, doing what we can to make sure that the cross-infection issues are mitigated, and try to get people back into the process of early diagnosis, awareness, and screening eventually.
Thanks, David. One of the big changes that we've had to make with the coronavirus pandemic is the switch to telemedicine. And all of us have had to come to grips with the new technology, be it by video, by phone, by smoke messages. So have we got any data in the UK that patients are satisfied with their experience? And I guess the person that might know best is the lung CNS. So Josie, what's your feedback from patients about virtual consultations? You know, do they work? And I'm really thinking about, you know, critical consultations, you know, for example, people being told they've got cancer or their disease is progressing. You know, should we be doing these by telemedicine? Josie?
I personally don't think any breaking bad news clinics should be done remotely. I think we still need that human face-to-face clinic scenario. I think that really is important. And I think the feedback we've had from patients where it's worked is more the routine follow-up, proactively checking how people are coping, certainly along with any exact treatments. But I think when you're giving such difficult news, then a person has to pass on to their family and their relatives, it's essential that we keep face-to-face clinics. And we've certainly tried to do that as much as possible. I think that's important. But there is certainly a place for virtual clinics, and it's helped. And I think everyone's had to adapt to that and are taking it on board. And certainly many of our elderly patients, you know, it's amazing how they can FaceTime, how they can use technology. And I think it's a real positive for moving that forward. certainly when we're looking at EHNAs, when we're looking at anything done electronically, you know, a lot of the criticism was, oh, people don't want that, they haven't got access. Actually, yes, they have. And it's been proved in many, many areas as well. I'm not aware of anyone who's objected to telephone calls, but when they've wanted to have a face-to-face consultation, we accommodate that. And I really think we need to continue looking at it as personalised medicine. It's just as important. We have to treat everyone as an individual in what they want. Some people can handle things remotely, many others can't.
I mean, the contrary is that some patients, you know, prefer having bad news at home. They're in their home environment, they're with their family, more family than they would bring in. You know, is it easy to tell what patients want? Do you get a feel as the CNS when you're supporting patients through the journey?
I think that's what we need to be addressing as soon as possible. Part of our role is, along with the optimal lung cancer pathway, is ringing patients at that point of abnormal X-ray or actually intercepting them in radiology, and you do get a feel for what's needed there. But I think again, it's personalising that, asking the question. You know, before we get to that point, would you be happy with a remote call? And if they're travelling distance, then certainly many people will. But I don't think we should make that the rule. I think we have to have exceptions to that, and we need to actually determine what that patient wants as part of that holistic assessment when they first arrive. I think we need to remember these patients are scared. They're scared of even coming anywhere near the hospital. That's why the footfall's been so low. And that will continue, I think, for a while. But if they don't understand right at the beginning what the diagnosis is, what it entails, what the treatments may be, we've got a very misunderstood patient right at the beginning. It will just cause problems, I'm sure, much later down the line.
Thanks. And John, you know, in your field, you really have to get a good feel of the patient before you take them on surgically. How's telemedicine worked in surgery?
So I think that's a very interesting point. I've heard colleagues seeing patients in clinic at the new patient consultation where the patient hasn't actually seen a doctor. And that is an interesting concept. And I think the word there is seen. You know, we're often asked in NDTs whether we would eyeball the patient. And I think you, even without knowing the physiology, the walk from the corridor to the chair in the consulting room tells the surgeon quite a lot. And I would think that probably 8 to 9 times out of 10, you can judge whether a patient is fit on the basis of that. What we have been doing is teleclinics, telephone clinics, but I haven't personally had experience of video clinics. And whether or not a video clinic allows the same eyeball assessment is, as far as I'm aware, unknown. It will be very interesting to see data. I mean, we all like data, and whether there will be any data about the safety and efficacy of different types of telemedicine. I don't know, but my personal feeling and that of my immediate colleagues is that we are continuing to insist on a face-to-face consultation for the lung resection patients.
Thank you. And David, perhaps a question to you. The government have been very effective in saying, if you've got a cough, stay at home. But of course, a cough is exactly what many of our patients have. So we've got a big problem in getting patients diagnosed, a backlog. How do we solve this in the UK?
Well, I think when we continue on with the endemic phase, if the message goes out again to not come to hospital, not come to your GP, stay at home if you've got a cough, all of those sort of things, then it will have the same disastrous effect that it's having at the moment and has had at the moment. And we have to get it. We have to improve. I mean, it's difficult. You know, it's the first time this has ever happened. Very, very difficult to criticise anyone, but we can certainly do it better next time. And the government will have to put out a mixed message. They will have to make it clear when they say you've got a cough, stay at home. They'll have to make it clear to patients that if you might have lung cancer or any other cancer, really, but lung cancer is the key one because it has overlapping symptoms, then they must put that message out at the same time to make it clear as it can be to patients. as you know, Sanjay, what we've done as the CEG was we produced a document called Differentiating the C's, COVID versus Cancer. And what that does is it tries to allow the primary care people who will be triaging patients once they've contacted them to classify patients into people that are very likely to have lung cancer, no features of COVID, people that are very likely to have COVID, no features very much of lung cancer, and then those all-important group in the middle. And then it suggests some relatively straightforward approaches to each of those categories, with the cancer patients just getting a swab and then being referred on the 2-week wait. The intermediate people basically self-isolating for 14 days to see whether they develop COVID or not, and having a swab and then being referred if they still have the symptoms. In other words, they're more likely to have lung cancer at that stage. Risk assessment being performed as well, of course, for lung cancer. And then the people that have classic COVID symptoms, well, just treated according to COVID guidance. And then if they still have symptoms that have persisted and therefore they go into the intermediate group, then they're then referred on for testing for cancer. And there's difficulty with uptake of this guidance because it's not national guidance. It is the first guidance that I've been aware that it's really tried to link the differentiation of symptoms with concrete action. There are national guidance documents available on diagnosis of cancer in the COVID era, but they don't go quite as far as saying, do this if you get this categorization. So I just hope that will get out and people will start to use it.
David, thank you very much for that. Well, we've come to the end of the hour. We could easily carry on for another hour with the questions that are coming through. So much to discuss. I'd like very much to thank the audience for their attention, for their questions. Very much like to thank our Dream MDT, our experts who have taken time out to give us their tuppenny bits worth of opinion on how we should be treating our patients, diagnosing, staging, and moving forward. I'd very much like to thank the BTOG executive for their logistics, as well as the production teams. And a reminder to the delegates, please complete your feedback. This is a new experience for BTOG, so we very much do want your feedback in terms of this particular webinar and your thoughts and suggestions for what you'd like to see moving forward. Speaking of that, moving forward, the next webinar that we are hosting as part of our BTOG webinar series is on Thursday, the 13th of August at 17:30. So mark it in your diary now. We will be discussing the World Lung Cancer 20 Virtual Presidential Symposium abstract session. There will be key, potentially practice-changing abstracts presented. We want to disseminate that information and we want to put it into UK context. Does it really matter to the UK, or is it just airy-fairy hoi polloi? So we'll be discussing that on the 13th of August. Be there, and thank you everyone for all of your attention. Goodbye.